Welcome to this clinical review on bradycardia and tachycardia. This presentation focuses on the critical management protocols for heart rate disturbances in emergency settings. We will examine the physiological definitions, pharmacological interventions such as atropine and adenosine, and mechanical treatments including transcutaneous pacing and synchronized cardioversion. Understanding these algorithms is essential for stabilizing patients experiencing symptomatic arrhythmias. We will proceed through the specific steps for both slow and fast heart rates, ensuring a comprehensive grasp of the advanced cardiovascular life support standards required for effective patient care and intervention. Let's begin by looking at the specific criteria for symptomatic bradycardia and the initial steps for stabilization. Symptomatic bradycardia occurs when the heart rate is less than 50 beats per minute and causes clinical distress. The definition of symptomatic includes the presence of hypotension, altered mental status, chest pain, or signs of shock. Step 1 of treatment is administering atropine 1 mg via intravenous push. You should repeat this dose every 3 to 5 minutes until a maximum of 3 mg is reached. Step 2 applies if atropine fails to improve the heart rate. In this case, you must transition to using transcutaneous pacing or initiate dopamine or epinephrine infusions to support the patient's hemodynamic status. Transcutaneous pacing, or TCP, is a vital intervention for unstable bradycardia. For the setup, you must place pacing pads in an antero-posterior position on the patient's chest and back. Regarding settings, you should set the rate, usually between 60 and 80 beats per minute, and then gradually increase the current in milliamperes until both electrical and mechanical capture, confirmed by a palpable pulse, is achieved. Finally, consider sedation. Because pacing is painful for the patient, it is critical to provide appropriate sedation or analgesia if the patient is conscious during the procedure to ensure comfort and cooperation.
Tachycardia with a pulse is defined by a heart rate greater than 150 beats per minute. If the patient is unstable, showing signs like hypotension, altered mental status, or shock, the protocol dictates immediate synchronized cardioversion. If the patient is stable with a narrow QRS complex, begin with vagal maneuvers followed by adenosine, giving 6 mg, then 12 mg if needed. For a stable patient with a wide QRS complex, you should instead consider anti-arrhythmic infusions, such as amiodarone or procainamide, to convert the rhythm safely while monitoring the patient's response to the medication.
Narrow complex tachycardia, often referred to as SVT, requires a specific sequence of actions. First, attempt vagal maneuvers, such as the Valsalva maneuver or carotid sinus massage, to slow the heart rate. Second, administer adenosine as a 6 mg rapid intravenous push, followed immediately by a saline flush. If there is no change in rhythm, a second dose of 12 mg should be given. A critical note for clinicians is that adenosine can cause a brief, startling period of asystole on the monitor. You must warn the patient beforehand that they may feel a temporary, uncomfortable chest sensation. Wide complex tachycardia, typically ventricular tachycardia with a pulse, has distinct treatment paths. If the patient is stable, consider anti-arrhythmic infusions, specifically amiodarone 150 mg delivered over 10 minutes. If the patient is unstable, the priority is synchronized cardioversion to restore a normal rhythm. There is an important warning regarding irregular wide rhythms. If the rhythm is polymorphic VT or torsades de pointes, do not use synchronized cardioversion. Instead, you must use defibrillation, which is unsynchronized, to prevent the shock from falling on the T wave and causing further deterioration.